Hello everyone, today we will be talking about diabetic retinopathy. Before going into detail of it, let me tell you one important thing. Diabetic retinopathy is the leading cause of blindness in adults. Now let's dive deep into it. The name diabetic retinopathy suggests that there is pathology in the retina because of the diabetes. And this pathology lies in the retinal microvessels of the both eyes. These microvessels are arterioles, capillaries and venules. So this pathology is called as microangiopathy. The cause behind this microangiopathy is hyperglycemia. Hyperglycemia produces two things. Number one is the damage to the endothelial cells and pericytes due to the accumulation of the sorbitols and the advanced glycated end products. Damage to the endothelial cell produces loss of tight junction, which is one of the component of the blood retinal barrier. So now microvessels become more permeable. That's why they start to leak out, causing exudate and hemorrhage in the retina. And this exudate causes retinal edema. And damage to the pericyte causes weakening of the microvascular wall. It's because they are the supporting structure of the blood vessels. So the weakened part of the blood vessel gets dilated, which is known as microaneurysm. When we observe the fundus with ophthalmoscope, they will be seen as a red dot associated with the blood vessel. The second effect of the hyperglycemia is occlusion of microvessels. This happens because of the basement membrane thickening or increased platelet adhesiveness, which may produce microthrombi and occlude the microvessels. This occlusion will produce ischemia in the retina. In response to the ischemia, retinal pigmented epithelial cells will produce vascular endothelial growth factors, which will cause proliferation of the new vessels, which is known as neovascularization. On another hand, ischemia may end up causing infraction of the nerve fiber layer, which will be seen in the retina as a white fluffy patches, which we call as cotton wool spots. So the exudates, hemorrhages, microaneurysms, cotton wool spots and a neovascularization are the signs of diabetic retinopathy, which are seen in the fundus during the ophthalmoscopic examination. According to these signs present in the fundus, clinically diabetic retinopathy is divided into 4 stages. They are mild non-proliferative, moderate non-proliferative, severe non-proliferative and finally proliferative. Basically, first 3 stages are non-proliferative and the last one is the proliferative. Suppose this person is a diabetic person. He can have type 1 or type 2. In both kinds, diabetic retinopathy may occur. Basically, the retinopathy is the effect of hyperglycemia, so it can occur in both kinds of diabetes. By time this person will start to develop diabetic retinopathy, and it starts with the mild non-proliferative, then moderate, then severe, then finally into the proliferative. It is not possible to have directly proliferative type of diabetic retinopathy. It always goes in the sequence. The major factor that determines the risk of having diabetic retinopathy is the duration of diabetes. Even the good control will not prevent the diabetic retinopathy, it will just delay. So ultimately diabetic retinopathy will develop in diabetic person in spite of having good control. If this person has additional risk factors, then this will speed up the development of diabetic retinopathy. These risk factors are obesity, hypertension, hyperlipidemia, renal diseases, smoking and pregnancy. Now let's study in detail about the stages. As the retinopathy starts to develop, the first sign that is observed is the microaneurysm. These microaneurysms are seen as small red dots associated with the blood vessel, and these are the only signs that are seen in the mild non-proliferative diabetic retinopathy as seen in this picture. In moderate non-proliferative stage, along with the microaneurysm, we see dot and blot hemorrhage in the deep layer of retina, as well as there are some yellow waxy structures which are known as the hard exudate. These are basically lipid droplet or the lipid-laden macrophages. Now even in severe non-proliferative stage, we can see all the signs in the previous stages, but their amount is increased. That is, more microaneurysm, more hemorrhages, and more hard exudates. Along with these signs, in severe non-proliferative retinopathy, we have some additional signs. They are venous beading or looping, intraretinal microvascular abnormalities, and infracted area seen as a whitish structure. They are known as cottonwool spots or soft exudates. To diagnose severe stage, we have a rule of 4-2-1, which means microaneurysm must be present in all four quadrants, and venous beading should be present in at least two quadrants or more, and IRMA must be present in at least one quadrant or more. Now let's clear the term IRMA. These are actually the new vessels which act as a shunt vessel to supply the non-perfused area due to the occlusion, as shown in this picture. And these vessels differ from the neovascularization of the proliferative stage as follows. In neovascularization, the vessels are small, fragile and leaky, and the blood vessels grow in between retina and vitreous. Sometimes they may invade the vitreous. Whereas in IRMA, the blood vessels are always prominent and they don't leak, and they are always present within the retinal layer. Okay, before finishing the severe stage, I want to add last point, that is, it has high tendency to progress into the proliferative stage. That's why this stage is also known as pre-proliferative stage, and the previous stages are known as background diabetic retinopathy. So let's finally move into the proliferative stage. The hallmark of this stage is the proliferation of new vessel, that is called neovascularization. If these blood vessels grow at the optic disc, then it is called neovascularization at disc. But if they grow anywhere in the periphery of the retina away from the optic disc, then it is called neovascularization elsewhere. In the severe stage, along with the neovascularization, we will find all the previous signs that we found in previous stages. So far we have studied about all stages of diabetic retinopathy. Now at last I want to add one important note, that is, the symptom may not occur in these stages if these signs are present peripherally and if there is no complication occurred. So symptoms are developed as a result of the complication. So let's see what are the complications of diabetic retinopathy and what symptoms they produce. The first complication that I would like to start with is diabetic maculopathy. It is the most common complication that occurs in non-proliferative diabetic retinopathy, whether it is mild, moderate or severe. It also occurs in proliferative, but it is not most common complication in proliferative. It is the most common complication of non-proliferative diabetic retinopathy. Diabetic maculopathy can be classified into the three types. Number one is exudative, number two is ischemic, and number three is mixed. Let's start with exudative. Exudative maculopathy occurs because of the presence of edema or the hard exudate within the range of the 1500 micron from the center of fovea. If this edema is limited to the particular zone in the macular area, it is called the focal. This occurs due to the leakage from the small microaneurysms in the macula. If whole macula is involved, then it is called diffuse. This occurs due to the extensive leakage of the blood vessels in the macula. So the exudative maculopathy can be focal or diffuse. If hard exudate or the edema are present within the 500 micron from the center of fovea, then it is called clinically significant edema. The diagnosis of the macular edema can be done by ophthalmoscopy or OCT, optical coherence tomography. The first picture here is seen through the ophthalmoscope. Here, hard exudate and edema is seen in the macular area, so this is the exudative maculopathy. The second picture here is the OCT, which is showing edema in the retinal layer that has caused the separation of the retinal layers with the formation of the compartments. This kind of macular edema is called cystoid macular edema. With fundus fluorescein angiography, it appears as the arrangement of the petals in the flower. So we give a term flower petal appearance for the cystoid macular edema. Now let's come to the second type of maculopathy, that is called ischemic maculopathy, which occurs because of the occlusion of blood vessels supplying the macula. This kind of maculopathy can be diagnosed by fundus fluorescein angiography. This is the fluorescein angiography of the normal fundus. Here in the center we can see small regular avascular zone which is actually fovea. This foveal avascular zone becomes enlarged and irregular in case of ischemic diabetic maculopathy as shown in this picture. Now the third type of diabetic retinopathy is mixed type, in which both exudative as well as ischemic type of maculopathy occurs. Now let's see what are the symptoms developed due to the maculopathy. As we know, macula is responsible for color vision and central vision, so these two functions will be disturbed. That's why the color vision of patient becomes washed out and the central vision becomes blurred. Initially, this blurring may be focal, but it gradually increases till the whole central vision becomes significantly blurred. So far we have completed the first complication, that is diabetic maculopathy. Now let's move into the complication of the proliferative stage. Complications of the proliferative stage are the result of the neovascularization. These new vessels are very fragile and they may rupture, causing the vitreous hemorrhage. If these new vessels are ruptured between the vitreous and retina, it is called pre-retinal hemorrhage. The blood accumulated will be pulled down due to the gravity. This will give a characteristic capital D shape to the pre-retinal hemorrhage. When this vitreous hemorrhage undergo organization and become fibrous, this will pull on the retina, causing the tractional retina detachment. And sometimes these new vessels may grow on iris or at the angle of eye, which may block the drainage of aqueous humor. That may lead to the increased intraocular pressure, which is called neovascular glaucoma. Now let's see the symptoms of these complications. Starting with the vitreous hemorrhage. If vitreous hemorrhage is small, they will block few light rays coming to the retina, producing a black floating spots which are known as floaters. And if this vitreous hemorrhage is very large or it is in the macular region, then the visual acuity will be dropped till the hand motion. This occurs very rapid and without any pain. Now the symptoms of the tractional retina detachment are appearance of the curtain in his visual field corresponding to the area of retina detachment. Finally, the symptoms of the glaucoma are headache, red eye and the painful drop of vision. So the blurring of central vision associated with washed out color vision due to maculopathy and overnight drop of vision due to the vitreous hemorrhage are the frequent symptom in the diabetic retinopathy. So if any diabetic person is coming with these symptoms, we suspect the diabetic retinopathy. Then we start our investigation with his blood sugar levels along with the hemoglobin A1C to observe the control of the diabetes over the last 3 months. Also, we will perform fundus examination with the direct ophthalmoscope to look for the signs of the diabetic retinopathy so that we will know in which stage the patient is in. Now there are second type of investigation that we use to detect the complications. We perform these investigation if there is possibility of complication as directed by the signs during the fundus examination. The first investigation to detect the complication is the OCT, which measures the amount and severity of the macular edema. The second investigation here is the fundus fluorescein angiography. This is used to detect the ischemic maculopathy as we have seen before and to see the area of neovascularization. Here are the two pictures of the same eye which is in the proliferative stage. The first picture in the red is seen through the ophthalmoscope and the second picture is the fluorescein angiography. In the first picture, the neovascularization is not so obvious. But when we do fluorescein angiography, The neovascularization will be clearly seen as a haziness around these newly proliferated blood vessels, as seen in this picture. This haziness around the neovascularization is due to the leakage of the newly proliferated blood vessels. The third investigation here that we have to do is B-scan ultrasonography. This is done when something is obscuring the vision till the posterior segment while looking through the ophthalmoscope, for example cataract or the vitreous hemorrhage. With these investigations we can detect the stage of the diabetic retinopathy and the complication occurred. Now let's move into the treatment of the diabetic retinopathy. We can study the treatment of diabetic retinopathy into the three sections. One is the control of the diabetic mellitus and the other risk factors present. Here the aim is to retard the progression of the diabetic retinopathy. Second section of the treatment is the treatment of the stages of diabetic retinopathy, and the third section is treatment of the complication. So let's discuss the second section first, then we will go into the third section. The first stage is the background diabetic retinopathy. In this stage, the person may be asymptomatic if he has the lesions peripherally. In that case, we will just try to control the diabetes and the risk factors, but this person must be kept in the observation because this diabetic retinopathy may progress into the next stage or may develop the complication. That's why he must be called for the follow-up every 6 to 12 months. But if the person is symptomatic at this stage, it must be due to the maculopathy. So the treatment goes according to the treatment of maculopathy, as we will discuss later. Now come to the treatment of the second stage, which is the severe non-proliferative diabetic retinopathy, also known as pre-proliferative diabetic retinopathy. This stage has tendency to progress into the proliferative stage. So we try to halt this progression by giving intravitreal injection of the anti-VEGF. At the same time, we give intravitreal injection of the steroid called triamcinolone acetate, which helps to decrease the retinal edema. And if the patient at this stage is symptomatic, that is if he has blurry vision, then the treatment of diabetic maculopathy is also given. And we have to call this person for the follow-up every 3 months. Coming to the third stage, which is the proliferative diabetic retinopathy. In this stage, there are new vessels proliferated which are very fragile and liable to produce complication. If these vessels are very little, then they must be burned with the focal laser along with the intravitreal injection of the triamcinolone and the anti-VEGF as in the severe NPDR. This person must be kept under strict observation every month because the proliferation of the blood vessel has been already started. If there is extensive proliferation of the blood vessel, then we have to perform panretinal photocoagulation. In this process, we burn all the retina, leaving the macular area intact as shown in this picture. In this process, we create about 2000 to 2500 burns, each of size 500 micron, and laser must be applied for the 100 milliseconds to create each burn. The distance between the burns must be half to 1 spot diameter. Okay, as we can see in this picture, the peripheral retina is already burned and is no more functioning. Only the central macular vision is remaining. So after PRP, the person will have tubular vision and will suffer from night blindness. After doing PRP, the patient must be followed up every 6 to 12 months. Now finally, let's move into the third section of the treatment, which is the treatment of the complication. Let's start with the first complication, diabetic maculopathy. If the maculopathy is focal, then we have to apply the focal laser. If it is diffuse, then we have to apply the guide laser. Here the aim of applying laser is to seal the leaking blood vessels. So the indication of the laser photocoagulation are proliferative stage and maculopathy. Now let's come to the another important complication, which is vitreous hemorrhage. Once there is vitreous hemorrhage, we have to remove it out because we fear of its fibrosis, which leads to retina detachment. Removal of vitreous is done by inserting an instrument through the posterior part of the ciliary body, so this process is known as pars plana vitrectomy. After removing the vitreous, we have to replace it by the silicone oil. And we have to provide pan-retinal photocoagulation as well, because there is already proliferation which led to the vitreous hemorrhage. Coming to the third complication, which is tractional retina detachment. Actually, the tractional retina detachment occurs after the fibrosis of vitreous hemorrhage. That means there is already vitreous hemorrhage. So we have to provide the treatment of vitreous hemorrhage, that is removal of the vitreous followed by the silicone oil injection and a PRP. Along with it, we have to do correction of the retina detachment. Its detail will be discussed in its respective chapter, but basically what we do is the drainage of the subretinal fluid and sealing of the break with the laser and scleral buckling. Now we came to the fourth complication, which is neovascular glaucoma. Its detail will be discussed in the chapter of glaucoma. So here we end our topic diabetic retinopathy. I hope this video is helpful to you. If you like the video, please give it a thumbs up. That really keeps me motivated to create more videos like this. And finally, I would like to say subscribe my channel if you want more videos.